So the idea, like you said, Uli, before, is for you to present some ideas on personality disorders and the perspective of BFT, and afterward we will have a small time for questions and answers, right? My idea was to present you a little bit. So I will say some things about you. You can correct me if I say something incorrect. But okay, Ueli Kramer holds a PhD in psychology, is professor for psychiatry, sorry, and psychotherapy, a psychotherapy researcher and clinical psychotherapist. He's a director of the Institute of Psychotherapy at the Department of Psychiatry in the University of Lausanne. I don't know if I said it correctly, probably not, in Switzerland. He holds an adjunct appointment at the Department of Psychology in the University of Windsor in Canada. His research focuses mainly on the process and outcome in psychotherapy, and in particular in the mechanism of change in treatment of personality disorders and case formulation in personality disorders. Dr. Kramer has published over 200 scientific contributions and over 10 books, including Understanding Mechanisms of Change in Psychotherapies for Personality Disorders with APA. He's a broadly trained clinician, author, and editor working with from an integrative psychotherapy perspective, in addition to being an ICEF-recognized supervisor in emotion-focused therapy. Uh, Dr. Kramer is past president of the European Society for Psychotherapy Research and past president of the European Society for the Study of Personality Disorders. And he's now the editor-in-chief of APA Journal of Psychotherapy Integration. And so I think you can maybe start now and share the screen and everything. And if you need something for us or whatever, you can ask.
Okay. Well,
Thank you.
Pepe, thank you, and thank you for this introduction. I hope when I think about and listen to this long introduction, I really feel it's a big honor to be here. For me to be able to talk about the project we're working on with Lazzo Timulak. So basically, this is the two of us, but today it's only me presenting some of our current ideas. It will really be based on the paper that's just in press in the Journal of Contemporary Psychotherapy. And I have lots of slides, but I will not present them all, depending on if you want to hear a little bit more research or more the concept. So it's really the proof of concept that I want to bring across this morning. Just looking how to come back to the slides. Can you see my slides now? Is this good? Okay. Okay, so I just need to, excuse me. Okay. Oh, is it now in full presenter mode?
Yeah. Yes.
Okay, and can you see when I move? Is this okay?
Yeah.
Sorry, it's checking.
Yeah.
Okay. So yes, a proof of concept. So it's really just kind of a first time we're working on this, really. But basically, it's bringing together everything we know as EFT therapists and also researchers. But of course, we talked about it in the beginning, but I want to give, before I go on, my thoughts to the victims of the fire in Gromontana, since in Switzerland we are still in the mourning phase, and tomorrow is our national day of mourning and related with this event that's extremely tragic, of course. A week ago, it's touched so many communities here. To introduce what I like to say, how I like to introduce the interplay between emotion and personality, I use these two pictures. So the relationship between emotion and personality is almost similar to, on a metaphorical level, to the relationship between rock and water. As you can see, the water is this fluid element that comes and goes, ebbs and flows, while at the same time the rock is something that seems totally immutable, that doesn't change, right? So when you look at the picture to the right, which I have taken when I traveled through the US at the canyon, Antelope Canyon, you can see that actually this dichotomy is not true, because these very stiff and hard rocks were actually formed by constant dripping of water over thousands of years. So it's a little bit similar when you think about the impact of trauma on personality. When there are emotional experiences over time, over the upbringing of persons, of course, we don't need to wait for thousands of years, but a few years are sufficient to actually leave a trace on the personality that are marked by the emotional experiences that are always the same, right, across time. And it goes the same way also for psychotherapy, in particular when psychotherapy focuses on emotion, that emotion is the fluid ebb and flow. That's actually healing these entrenched structures that look as if they do not move. And of course, they do not move in the moment, but of course, when you look at these interplays and dynamics, they do move. So let's ask the question, what is personality and what is personality disorders? So what the personality is, it's the persona, the public face of one's identity. Antiquity, the theater mask as a kind of actor wore to express different emotions and attitudes, but it is fixed, right? And certain expressions led to specific, commonly admitted interpretations without ambiguity. So really, it's something that's stable, right? When we read the American Psychiatric Association DSM-5 definition, they say that personality disorders, kind of the pathological part of the personality, is an enduring pattern. Again, it's quite stable, right? Of inner experience and behavior that deviates markedly from the expectations of the individual's culture, is pervasive and inflexible here, hence the stability, has an onset in adolescence and early adulthood, and is stable, here the name, over time, and leads to distress and impairment. So this definition is quite comprehensive, I think, and it really reflects the stability piece I mentioned earlier. But of course, we want to question when we do psychotherapy how this stability can be changed through new emotional experiences. So this is not new, what we're doing here, of course. Gendlin in 1964 has been, in my understanding, one of the first humanistic thinker who has actually written about personality change in a chapter. And he differentiated two streams of change. One is the feeling process, that the change comes through some kind of emotional digesting, and we must understand what this is. So by really focusing on what the client is doing, I think that's different from other types of approaches. And he also acknowledged that there's a second process, that's the relationship process. And I do think that this differentiation between feeling process and relationship process is still where EFT for personality disorders should stand on. And I will give the elaborations on this a little bit later. So the current definitions of personality disorders should differentiate between what personality is and what it does. So that's more the descriptor. So really describing this self at a stable set of features, traits, right? How extrovert a person is, how strongly the person leads to is igniting conflict and so forth. So these are traits, right? But also what it does is more the functional component of personality or personality disorders when it's a disorder. So what's actually the impact, mostly on the social world, of a personality disorders? So this leads us to two aspects: description of traits and the functioning or impact aspect in daily life. This is today we have two aspects when we diagnose from a dimensional perspective personality disorders. One is the severity, that's the impact, that's the personality does, and the other is the pattern or the pattern of traits, which is the five trait domains that we talk about today. earlier conceptualization have, of course, as you know, talked about categorical conceptualizations. We talked about dependent personality disorders. We talked about narcissistic personality disorders. We talked about paranoid or borderline personality disorders. Except the latter, we tend to go further and not use these categories as much anymore, although I acknowledge that many clinicians actually found them quite helpful still nowadays. Okay, I'm not going into the last 2 points for the question of time, but why even talk about personality disorders? I think first we need to acknowledge there's a high prevalence in clinical settings. So if you open up a clinic, you will have 20 to 25% of consultations in psychiatry, inpatients even closer to 50%. Effectiveness of treatment is affected by the presence of personality disorder. This is quite old research, but it's still correct, right? That treatment of depression, substance and alcohol abuse is less effective if a personality disorder is present in the beginning of treatment. This comorbidity affects the course of treatment. So once there's remission in depression, for example, a shorter time until depressive recurrence or adaptive relapse is observed in the case of personality disorders. For personality disorder patients, a low level of motivation is observed. These are observed to be ego syntonic problems. That means that they actually perceived by the person as being part of their own personality, really, of their own self. So it's much harder to change. So 2026, we're talking about two aspects of diagnosis, level of severity, and this is ICD-11 here, how we diagnose personality disorders, 2022. We have 4 levels. One is clinical subthreshold, that's personality pathology, and then we differentiate between mild, moderate, and high severity. The question is, how do you actually diagnosed this? There are questionnaires you can use, the PDS, for example, but for the first part, this functioning part, what the impact of the personality is, we have 3 aspects. We talk about dysfunction of the self, dysfunction of interpersonal relationship, and this dysfunction on the emotional cognitive behavioral manifestations. This was the first part of the diagnosis, really appreciating the severity index of a personality or personality disorder. And now the second part is really this descriptive part, as I said before, right? So here we have a model in ICD-11, but also DSM-5 of 5 patterns of traits that are negative affectivity, to what extent the person always falls back to ruminative and negative interpretations, expression of negative affect, for example. To what detachment, to what extent the person is both socially detached, but also emotionally not in touch with themselves. Disinhibition, to what extent does a person let go of inhibition and actually be completely impulsive? To what extent, with this sociality, to what extent does a person actually ignite conflict, oversteps boundaries, must be taken back by the police, and so forth? And anancassia, which is to what extent does a person actually, functions in an orderly fashion until becoming very, very rigid and aligning with norms. There is a third step in diagnosis of personality disorder, that is the borderline specified in ICD-11. I'm not going into all the details on this slide, but I really want to make the case that we can still, after we have looked at severity and the patterns of traits, we can still diagnose borderline personality disorder according to these 9 criteria that are the same as in DSM-5, which is really a huge step forward in classification, that there are 2 classifications internationally that agree on these 9 criteria. However, I also want to highlight that the construct of borderline is criticized. You can see here all the 120 criteria of all personality disorders, categorically speaking, right? You can, and this is that describe these 120 features on a hetero assessment given to 2,000 soldiers and or there are 2 samples, over 1,000 students. They were asked to rate their roommates Of course, soldiers and students, they know their roommates very well because they either share their rooms or their space on a regular basis. So, and these tend not to be severely ill persons, so they actually, like you and me, right, have some traits of personality, maybe one trait of personality disorder here and there, but not completely dysfunctioning. So in this population, these two samples, you can see here what a project here. Well, first, what you don't see is the colors of the 10 personality disorders, such as narcissistic, dependent, and histrionic. They all group very well together on this bidimensional space. So the items for histrionic, they are in one corner. The items for, and they're linked together. So if you have one, you have a higher likelihood to have anything else on this particular diagnosis, right? And for narcissistic, paranoid, and so forth, it's the same. They're all very well differentiated. You don't see it here, they're all in gray. What you can see in orange is actually the 9 criteria of the borderline personality disorder, which is completely scattered in the two-dimensional space. What this means is that persons who have no diagnosis by definition, or likelihood of low likelihood of diagnosis, will not have, if they have one criteria of borderline personality, it will not have any other diagnostic criteria of this particular disorder. Let's talk about psychotherapy. Psychotherapy is the first line intervention for borderline personality disorders, in particular dialectical behavior therapy. This is already quite an old meta-analysis, but still actually the conclusions have not changed, where we can conclude that dialectical behavior therapy, different forms of psychodynamic psychotherapy, and psychiatric treatments are probably effective for the treatment of BPD. And you can see here the consistency across studies. There are 2 exceptions, I believe, or 3, which I can talk about later. When we talk about personality disorders more globally, all personality disorders, there's a similar effectiveness that can be shown. It's not just borderline personality disorder. I also want to just talk about a little bit what are these different types of treatments that are in these meta-analyses. So let's talk about the gold standard, that is dialectical behavior therapy. This therapy developed by Marshall Linehan addresses severe personality disorders and quite diverse personality disorders, and talks about a lot of emotion regulation as a mechanism of change. Good psychiatric management addresses high severity as well, and talks about interpersonal hypersensitivity to integrated emotional responses. Transference-focused psychotherapy also addresses moderate to high personality disorders and talks about diffused identity and so forth. And we have in the end here emotion-focused therapy, which is not, we don't have any studies to demonstrate that it is effective yet, but we would argue that it is addressing moderate personality disorders intensity, and the mechanisms of change, of course, are related with from moving the client from emotion indifferentiation to emotion awareness, emotion expression, emotion regulation, emotion transformation, and memory reconsolidation. This is consistent with the perspective on mechanisms of change in psychotherapy for personality disorders, which we published 2 years ago with Shelley McMahon and Ken Levy, where we developed 5 or actually 6 pathways of change in any psychotherapy for personality disorders. I'm not going into details, but you can see here, this is the model we developed based on several case studies. However, what we think actually is that emotion is central for change in these entrenched structures such as personality disorders. Emotion regulation contributes to emotional balance, really to be more balanced, to be able to accept all kinds of emotions. Awareness builds interpersonal effectiveness. So if you want to move towards interpersonal effectiveness, you also need to know what is your emotional response to the other person. So you need emotional awareness. And emotional awareness and transformation strengthens the identity. Emotional awareness is the cornerstone of awareness, self-awareness of the self. And emotion is the core to develop a new bodily anchored narrative about the self. So you can see these aspects around identity, self, interpersonal aspects actually at the core. Um, the, with Laxotemolak in 2022, we highlighted 3 areas where personality disorders are different from any other treatment from an emotion-focused perspective. I'm going quite quickly. This is quite old, right? The first one is difficulties in emotion regulation or over-regulation, over-control of emotion, right? So this is where we need to pay attention as therapists. This is the first domain where we need techniques, interventions, tasks to work to before probably we go deeper into the emotional experience and transformation. So the first is problems, emotion regulation, and or over control. The second is the problematic interpersonal impacts of emotion. This is an important piece. Sometimes personality disorders are actually defined as interpersonal disorders. And in the paper, Kramer Timbolak in the Journal of Contemporary Psychotherapy, we actually start by saying personality disorders are really emotional disorders. So this is kind of the case we're making there. Why? It is because kind of the glue or the mechanism within the interpersonal functioning is really how the person responds emotionally, and the person's awareness about his or her own emotions in response to the other. It is more complex than just responding, of course, because we know there are instrumental emotions. EFT therapists, instrumental emotions may be, for example, in the form of expressing suicidal hopelessness, so that the other is more responsive to me, stay close to me, and prevents that I feel the shame that is actually my core emotion of being rejected by the other. You see? So there is a complex interaction between a primary maladaptive emotion, the shame here in this example, and the more instrumental emotion that is typical for these interactions with persons with personality disorders. These patients adopt by default an external focus. They are actually, because of that, very skilled to read others' emotions. So tests have shown that theory of mind is actually increased in persons with notably borderline personality disorders. So they're actually quite skilled. They're actually very good outward looking, maybe good therapists to some extent, but they actually neglect their emotional awareness of their own body cues. So using Greenberg's theoretical basis, the example here really is that the emotional response depends on the interaction between the internal schematic processing, kind of the wired stuff, right? And the value of the anticipated emotional response. So the example would be here when the person faces the experience of interpersonal rejection, as in the example above, a client may detect in her body, like, as I said, of course, the person is very skilled to look outside, but they may misread their body, a discrepancy between her schematic processing. I cannot trust anyone. This is kind of what I believe and I feel fundamentally about anyone, leaving me very lonely, and the value of what is a primary adaptive emotional response. I need somebody. I need connection. So this discrepancy will result in awkward resolution. These are the antagonistic interaction strategies that are very typical of persons with personalities. So this is kind of the theoretical elaboration, how we understand in-session instrumental behaviors. And finally, the third domain, so we have emotion regulation, dysregulation, over control. Second, the interpersonal aspect with these dynamics I explained just right now. And the third, specificity, is the emotion-based problematic meaning making. So the narrative about one's story is mostly either too emotional or completely abstract, or even confusing. If you talk with a client with personality disorder, this person may not give you a clear account of who she or he is. So that is one part of sometimes a bizarre presentation. So this is the model we presented in 2022 with the 3 components. They all explain the personality disorder and the trait patterns. So When it comes to change and how understanding change, and this is really, I think, an EFT model. It's not very complex, but we would propose to have three levels of understanding. We have the functioning, that is actually the severity, right? What is the impact of personality? And this is kind of over time, over a year or even 2 years of stability, right? Then on a narrower time bond, traits and patterns, right? What is how I usually respond to interpersonal stress? And then the states, this is the ebb and flow of my emotions in response to the interpersonal cues. And this model is the model at the core of understanding how we work with emotions with these patients. And now I go through the main 5 emotional states that we outline in our 2026 paper. The first pattern of, these are, of course, states, but sometimes they become patterns too, right? So the first one, of course, is shame. Shame, I put that together with guilt and self-contempt. We all can define, but why are these together? They're functionally similar. They emerge when, in particular, for example, if we conduct 2-chair dialogues focusing on self-criticism, in particular, the shame, the self-contempt emerges in the critical voice. And the person could say, as example for shame, I feel so small, I have no control, it's all my fault, I have provoked the aggressors to do what they have done. So really, this is the one of the core piece that needs to be worked through, activated and worked through, completed in EFT. The fear in an empty chair dialogue with the mother is really this maladaptive fear. I'm afraid that you hit me again, that you are targeting me. I want to turn away from you. I want to protect myself. So you see, this is really the root of all the avoidance behavior. I mean, there's cognitive therapists who talk about avoidance behaviors in personality disorders. So this is the root of all this. The loneliness, that's really a core feeling, particularly if you do empty chair dialogue with unfinished business. For example, here with a father who was absent, the patient could be saying something like, well, this was a real patient. When I was speaking to my father like this, he is more commenting on the empty chair dialogue. I feel so alone inside. It was that nothing could reach him. I felt so alone. It's so sad, really. It's pointless to even try to connect with him. And see, this person has really just come into a hole, right? A hole to where nobody can actually reach him. And this is how he describes it. Another hole, I could say, emotional hole, that's maladaptive emotion or secondary emotion, is the hopelessness and helplessness piece. I feel not sure what it is, but I am just unwell and it's so unbearable. What is happening? I mean, the trauma, the insurance, the boss, and now my boyfriend. There's just so much, so I give up. So you can hear a strong secondary component to this here, this expression. And finally, we see the problematic anger as, a more destructive anger. I feel not sure what it is, but I am just angry all the time. It's so unfair how life treats me. So this is an anger that also needs to be undone, which is of course the rejecting anger. So we do have, of course, as EFT therapists, we know where the trajectory of change is going with Antonio Pascual-Leone's model. So this is the triad which facilitates emotion transformation. That is the experience, access, the expression of self-compassion, adaptive grief, and assertive anger. Yeah. So that will undo the expression of. I'm not sure if I should say any of these 5 I presented, but this is the antidote to some of these at least, right? So we need to make sure that we let emerge through the task to facilitate one or more of these experiences in the client. And this is the feeling process and the relationship process by Gendlin is kind of the context to this. So we foster a corrective emotional experience with us as therapists. We are very much involved as therapists in the therapy relationship. We make sure we create conditions that help the patient to update negative memories in the relationship with close others, including ourselves. So this is really going to a deep level in terms of how we make changes. So this is really the sixth path, and we have a task for that, of course, resolving aligned structures, which I can talk about a little bit more. But the principle really here is that we want to stimulate memory consolidation through the path of alliance rupture resolution. Emotional memory is an interaction play out in the therapeutic interaction with psychotherapists. So the patient, and sometimes I hear therapists from other therapy approaches say, well, patients with personality disorders do not trust the therapists. This is a huge problem. We need to fix it, and so forth. So this is kind of a language that I could understand being quite invalidating to the patient's experience. I say, and we say, that actually patients who express that they do not trust the therapist, right? As I don't trust you, right? That I understand that they're exactly at the right spot. They're actually where they should be at, because they're really expressing their core emotional feeling about relationships. And now it is our job to retrieve old memories, activate these memories. They enter a labile state in the therapeutic relationship, old memories, which are maybe traumatic, of course. And we will be working using the principles of memory consolidation through a corrective emotional experience in the therapeutic relationship. So this is the model by Richard Lane, of course, where semantic structures, that means what it means, who I am as a person, not trusting the other, and so forth. Emotional arousal, I'm actually activated in the relationship with this therapist because this is something new, unusual, and so forth. And the episodic traumatic memory that brings me back to my relationship with my father, for example, that has to be expressed and activated. So the three aspects need to be expressed and activated in the therapeutic relationship. This is, well, I'm not going into the details. It is more a computational conception. The time is a bit short today. So what are we doing? So basically, this is 10 tasks. They are not absolutely new, which is actually why I'm not spending hours and hours, because this is something as an EFT therapist you know how to do. But basically, everything I said until now leads to this slide. That is, we do have in EFT good tasks that may be effective if we distill them and we propose them in the right moment, addressing either of these three components and then pay attention to really heal the 5 problematic emotions or maladaptive emotion states I mentioned. To create new emotional experiences. So first is, of course, empathic soothing. And we're really going in with a lot of empathy and really using a calming voice, calming presence to help the patient in the relationship with us regulate and help being regulated. The breathing, of course, sometimes I have patients when they come in, they're quite all over the place. So the grounding of breathing, being aware, has a lot of built up a lot of skills in the patient. Um, uh, this is also coming back to, this is a moderate. We focus here on moderately intense or severe personality disorders, not on the most severe end. The most severe end, probably they need a more guided and I will come back in the very end of the presentation to this, the really probably dialectic behavior therapy or just the skills that are the groundwork. At least that is our understanding where we are today in January 2026. Clearing a space is an intervention that we know from focusing. So it's something that's really helpful in patients that bring a confusing narrative, for example, or a lack of focus in the narrative. If we do have a lot of symptoms, and any of these problematic emotions can be also translate into some type of symptom in personality disorders, then of course we want to help the patient to self-soothe, to have a competency, skill that persons can self-soothe. Not only give us the soothing, but they help that they soothe themselves so that they focus on the underlying issue. So this is very similar to the transdiagnostic evolution of EFT developed by Latzo Timolak. And of course, self-interruptive splits, they're all over the place. It's basically we need to choose the right one to be effective. We cannot always treat all of them, but the most important one are the ones that but the splits are in relationship with the body of the person. So if somebody does not focus on their bodily experience, that's well, I implement an exercise, breathing exercise, for example, or I address this as a self-interruptive split. With the two chairs, of course, two chairs dialogue. Then this second domain is a large domain, how to address the interpersonal impact of emotion. Of course, again, offering a compassion, validating presence. I'm completely accepting what's coming. I'm also stepping up. I'm not hiding in a technical relationship, but I'm actually true and authentic in my way of relating with the client. Resolving alliance ruptures, that's of course when the patient comes in and said, I don't trust you. As I said before, we do have the need to really repair this. And with the principles of memory consolidation, we can go deeper than just agreeing on some tasks, but really go deeper into the emotional and interpersonal issue that is underlying the rupture to repair it completely. When the therapist feels that boundaries are challenged, there's a technique we want to propose that we actually focus on the underlying pain. Of course, boundaries are challenged many times in these interventions and therapies, but the underlying pain is where the money is, I would say. So going really back to the patient, to the client, and actually looking at the underlying pain is crucial. And this is really looking at the impact, the impact of the emotion, like the instrumental emotion, and undoing the impact of the instrumental emotion. We need to do this explicitly because there are so many instrumental expressions of emotions in patients with personality disorders. So we need to have a task that's really at the level of these difficulties. And then finally, we only have one task to actually address problematic emotion-informed meaning-making processes, that is creating a coherent narrative. Maybe we can develop in the future more detail here, but this is of course an Linangus work that has also shown already some validity in personality disorders. So actually, maybe I just want to skip the research now. I'm happy to come back. So sorry, so I need to just go through quickly. I'm sorry, because I did bring lots of research. So to kind of conclude, before I'd open it up. So are they actually different, these interventions using EFT for personality disorders from our basic EFT, right? So what I would say, based on my clinical experience, from the research I have consulted, that EFT may work with clients with moderate and mild levels of PDs. And if you have severe levels, well, this is not a good formulation, severe levels of personality disorders, use DBT, dialectical behavior therapy, or something else that's actually well validated. I think that's where we are at the moment. We don't have any outcome research. There's case study work published, but we don't have a good outcome study. So this is something which is really the next step. We should be mindful of the specific difficulties. First, emotion regulation over control, impact of the interpersonal impact of the emotion, and the narrative meaning-making components. And we need to make sure we go through, really arrive and go through, transform the 5 problematic emotion states or patterns, depending on how it's presented in the client. And one big first step is really fostering emotional awareness. We have a paper recently published in the Journal of Personality Disorders with Richard Lane and colleagues on emotional awareness actually as a trans-diagnostic, a trans-theoretical mechanism of change that is at the very beginning of work, therapeutic work, any therapeutic work with personality disorder patients. And this goes emotional awareness in the patient, in the client, in the moment of therapy, and the emotional awareness in the therapist in the moment of interacting with his or her client. Use the knowledge from memory consolidation in the creation of a relationship, and then use the 10 tasks within the 3 domains as outlined. I also want to highlight that we are organizing here in Lausanne. Maybe this is something to present some of this work. The call for paper is open right now. In September, the next European Society for the Study of Personality Disorders Congress, where I'm actually the current past president here in Lausanne with this beautiful picture. So maybe you want to join us in September to discuss more personality disorders research. It's not only focused on psychotherapy, but on personality disorders. So thank you for your attention. And I think we have time for questions.
Well, thank you very much, Yuli, for the wonderful presentation. So thank you very much. And as you said, we have some time for questions. So I don't know if someone has any question. I have some, but I will let other people speak before me.
I have a question. Do you hear me?
Yes.
Yeah. Okay. Thank you for the presentation. I was wondering, because you mentioned trauma and complex trauma. I was wondering was trying to figure out what's the process there so people develop personality disorder and other people don't. What's your take on that?
Okay, so
Thank you.
first of all, I'm like, thank you. This is, this question is really the first question to ask of this presentation. So thank you for asking it. So basically, the first answer I want to say, the first thing to clarify is that personality disorders is not exactly the same thing as complex trauma. I know some other researchers may disagree with me, but really the research shows that not everyone with personality disorders have a complex trauma history, but many do. So there's really an overlap between 70 to even 90%, depending on the studies, of actually presence of trauma in the history of persons with personality disorders. But what we can say, today, that there's a complex multi-determination in the etiology of personality disorders. That's kind of the model we're using. It's not just trauma. There's other stuff going on. It's also genetic vulnerability. It's a type of, that seems to a developmental trajectory in personality disorders that's quite specific. That's not the same as in complex trauma. So there is, with the young adulthood actually as a key moment between, let's say, 15 and 25 years of age, where these patterns and traits and are actually consolidated, so to speak. Okay, so in terms of intervention, of course, in the clinic is then everything is possible. You may have a client with a personality disorder without any trauma, and you can do what I presented. But of course, you may have a client with personality disorders and a lot of complex trauma problems, including flashbacks and a lot of avoidance and so forth. So this is more complex, of course, but we do luckily have good, guidelines in EFT to work with complex trauma. It's Pavia and Pasqualeone's book now in the second edition. That's really the way to go. And there's also different ways. There's of course, some of it is empty chair work, but some is also more narrative work that's actually important depending on really on the emotional processing style of the person. But I would really, as a guide, really assess emotional processing first to see where are really the core problems, and then based on Is it more the interpersonal part? Is it more the emotion dysregulation, the narrative part? And then use either of these avenues to focus on. Yeah. Does that help so far?
Yes, thank you.
Yeah, thank you, Uli. It was fantastic to hear you. I was wondering what was the role in relation with trauma, but maybe because it surprised me a little bit that among the 10 tasks you presented was not included self-criticism or unfinished business. What's your take on that? Is because it's too much emotion for the beginning?
Sorry. I think I wasn't clear. I'm sorry so I make it clear right now. These are additional tasks that we are making sure they're specific to the personality disorders. But any other tasks are, of course, needed, in particular, if we want to really heal these 5 problematic emotions we outlined. Is most of the time it's work with unfinished business, empty chair dialogues, going back into the biography and really letting speak that child that has been limited, violated, and so forth. And of course, self-criticism is needed to really access, let's say, point and clarify, put words on the contempt. When I work with patients with personality disorders, a lot of times, and that's also for narcissistic, let's say, coloration, a lot of contempt or very, very, very harsh self-criticism is really present. That is really kind of just, it's very similar to clients with depression. It's just more intense and more defining and more stable, right? So what I find as a clinician is that more repetitions, going back to the same task with the same content, maybe in order to come to the same results, which is, not something completely new in the literature. So others have described similar, in other approaches, it's quite similar. But I really want to highlight that there is so far it has been overlooked that we can directly work with emotions with these clients. The conceptualization usually in the personalities or the literature, including at the Congress, I think in September, will be focusing on interpersonal problems as kind of the, let's say, the unit of work in therapy, right? Which is meaningful. That's what's present clinically most of the time with these clients. But my argument goes a step further. I think in order to really undo the interpersonal problems with these patients, we need to understand their emotional response and awareness about this response in order to be able to change it.
Thank you.
Any more questions? I think, Pepe, you had a lot of questions.
I have some. Yeah, one of the question I have, you said something that you work with the interpersonal impact of the instrumental emotions.
Yep.
So my question is how you do it, and also if you do it with secondary emotion, because I was thinking about, for example, a very explosive anger that can have an impact on relationship, or so how you do it, really, because you say something about exploration and.
Okay, so there's even several questions in one, as I hear.
Yeah.
But if it's explosive anger, for me, this would be really somebody who is probably very highly aroused in the moment and will not have any capacity before this anger is at least a little bit downregulated. So I can, that the noise is not so strong. We can actually talk about it and elaborate a little bit, so make meaning and so forth. So if this is so high that this, there's probably some grounding work, or just come breathing and just have a sit down and breathe and be aware. Awareness, body awareness exercises would probably be the first place to start. Is my, is but I am aware of the second part of the question, that there may be actually, this is almost secondary. And of course, my observation is many therapy approaches stop there, right? They contain the patient, they, help to downregulate, and then think actually everything is fine. But actually the main work starts right there, because we're only talking about secondary or instrumental emotions. And we have not touched and not understood the actual pain this person is going through. So I would rather quickly, once the person is actually, we can have, the person is not so explosive anymore, really go into into some more deeper work. But and then it's not different from classic EFT, really, to go, what's really the underlying hurt in the expression of the anger.
Okay.
And probably there's also shame. And there's anger in the personality disorder's expression. Somewhere there's shame. It's just my understanding clinically. So I would probably also be aware that we shouldn't push too hard too quickly to the hurt, but probably there's a lot of shame.
Okay, thank you. I don't know if anyone else has questions. I
hope it makes sense.
Yeah.
With your clinic, I mean, maybe you have a case, or we have 3 minutes, but
No, I think make a lot of sense. I was thinking also about this instrumental emotion. You said something like exploring the interpersonal impact of them, like this kind of emotion.
Yep.
So you do like exploration and how you do it. I don't know if it's any specification for it, or it's more like general exploration.
So my core strategy would always be to internalize and to actually, well, both to accept what's there, but also to go for the underlying internal piece, because it is fundamental external focus, right? So, and I'm just aware that everything we do, if I explore the instrumental emotion, will be focusing on the external focus, right? Which is not the therapy I would want to propose. Right? And I wouldn't expect that there's much deeper change if I just explore the interpersonal impact. Although it may help the patient to be aware of the interpersonal impact of their expressed emotion on the other, in order to be motivated to do the deeper work. So that piece I think will be important. But I would always kind of, when you express yourself so strongly to your partner, how do you feel about this? What is going on inside you, right? I would be very curious about the internal world of this person, and really go back to this, and if needed, to actually do it in a in one of the tasks that would be helpful at this moment. And then actually at the moment of expressing the emotion, really be aware that I need to go back to the awareness of the inside world as the person is expressing an instrumental emotion, right? So that's the key there. That kind of, I want to go under this. I would not do just the impact of the interpersonal. That's just one task, right? But it's not the end of the story.
Thank you. Yeah, that make a lot of sense. Yeah, thank you. So I think we have time for another question, if someone has something in mind.
Yes, thank you for your presentation. I want to ask, because this is very important to go with this underlying pain, and in personality disorder is very, very difficult. And I want to ask, when is the right moment to go?
Yeah. Well, the question is, what do you mean with goal, really? I would say the right, this is even abstract question, because everything will be different for each client and each therapist. But that's why I do think what we have underrated so far is actually emotional awareness in the client and in the therapist. How deep, what is my awareness right now in my body with this client, my experience of this person, right? And I think we even need to have, but this is maybe a little bit futuristic, new module of training our EFT therapists on their emotional awareness with these very challenging situations, right? What can we actually take up from our own emotional and body reaction right now? So that's why there's not a formula, right? But there is a path through the emotional awareness of the therapist in the room that I would say is important. It's kind of the first step towards knowing now it's the time to, and now if I propose something, it will land where I intended to land, and also I will not harm the person, because that's kind of what you imply a little bit, that if we go and push a little bit as a therapist, then the client will maybe shut down or not feel confident anymore in the therapy and so forth. So, but this is ultimately a more, these are the decision moments for the therapist, but the decision can only be taken when the therapist has a high level of deep emotional awareness, I think.
Thank you.
Does that make sense to you? I mean, it's
Yeah.
general response.
No, thank you.
Yeah.
Yeah. Thank you.
Well, I think that's it.
Yeah. Well, thank you. Let me check my thing. Sorry. Yeah. No. Thank you, Uli, for the wonderful presentation, and I hope everyone like it. I'm sure of it. I really like it. I'm very grateful for your time and the presentation and your ideas. I'm hoping to read more of next papers and everything, because I read the last one with Lazzo. I think was wonderful.
Oh,
So I
thank you.
hope to read more of it. And I really thank you for everything.
Well, and see you soon in person, I hope, or online somewhere. Okay. Good seeing you. Thank you for the invitation. I really enjoyed being with you guys.
Thank you.
Thank you
Thank
so
Have a
you,
much.
good
Uli.
day. Bye.
Thanks. Bye.
Thank you.
Bye.
Bye bye.